Welcome, everybody, to our July Utah Children's Care Coordination Network meeting. We're glad to have you here today. I will just go over a few announcements and things to get the meeting started. A look at our agenda. We'll have some time for case sharing and brainstorming, and then we'll move into our learning session today, which is all about intellectual disability and co-occurring mental health illnesses. And then we'll plan to wrap up by 9:30. So just as a reminder, if you can go ahead and update your Zoom profile so that we can see your full name. We used to require registration for this meeting, but since we do not anymore, here, I'll show you how to do it. You click on this um, on the little icon at the left of your picture, and then it'll allow you to edit your name. So if you can include your agency, that's really helpful for us in taking attendance in your full name. And then if you're joining us for the first time, we'd love to have you introduce yourself in the chat as well and include your email so that I can reach out to you after the meeting to add you to our listserv and so you get all our announcements and everything. So for our announcements today, I wanted to remind everybody, I sent an email about this morning as well, but it's time for our mid-year evaluation. This is part of the requirements for the HRSA funding is that we do evaluations at the beginning, mid, and end of year. So if you haven't had a time to complete the evaluation yet, we'd love to have you do that. There's a QR code that should take you directly to the link, so you can do it on your phone, or you can look for the email that I sent this morning out through the listserv. It's linked there as well. So just it's very short, 2-question survey. So if you can complete that, that would be really helpful for us. And then I will close that survey at the end of tomorrow. So if you can get it done today, that'd be great. And then I wanted to let everybody know that we've launched a new web page. This is an embedded page in the Utah Department of Health website. And I'm actually going to take you out to the website right now so we can look at it a little bit more closely. I do not know what this line is here on my screen. I must have doodled on my screen on accident, and I'm not sure how I did that. So sorry about that. I'll see if I can get that removed here in a second. But so it's pretty bare bones at the moment. We would love to have some input and feedback about things that you would like to see added here, but we have a little bit of information about benefits for members, the links for the Zoom meeting, and also the YouTube channel where we archive all of the monthly meeting recordings. We have our calendar of scheduled topics for the year, and then some resource links at the bottom. So we, again, would love you to visit this site, send people to this site at this page if they're interested in learning more about UCCCN or joining. And then also, yeah, if you have any feedback about what we should add here, we'd love to kind of grow it over time, but it took a bit to get launched, so we're excited to have it there. All right, and then last month we had a question about complex billing codes. I don't know if Brooke is on. Is she on? I haven't had a chance to look at the.
Yes, I'm here.
Yes, you're here. Great. Okay, well, this one's for you, Brooke.
All right.
So, I was able to dig into complex billing codes a little bit, and I got a little bit of feedback on 2 options that can be used. So there's this prolonged service code 99417. It can be reported in addition to the primary E and M code for a new or established patient for at least 15 minutes beyond the maximum time. So one thing it does require is that you record kind of like start and stop times. And I, at least within the U Gen Peds department, it's the experience is that it actually pays fairly well, is reimbursed well by insurers. So for example, if you had a level 5 established patient, you'd bill the regular 99215 code, and then which is typically 40 minutes, and then you could use the 99417 if you exceeded that cap time of 40 minutes by at least 15 minutes, if that makes sense. Any questions on that one? It does have to be done on the same date of service. So that was, I talked to Jason Fox about this, and he said he really, in one thing that it may require is change in workflow so that providers are doing all their prep, like if they're reading through charts and things ahead of time on the same date of service. So that is one option. And I'll send all this information out in the notes too, so don't worry about trying to memorize it. There's another service code that can be used. It's a non-face-to-face prolonged service code 99358. It can be used before or after a patient visit, so it doesn't have to be on the same day as a visit. It can be used to report each additional 30 minutes beyond the first hour. So it does not reimburse as well as the previous one I just mentioned. Some insurers may not cover it. But if, for example, if a physician spends 45 minutes reviewing a patient's chart before an upcoming telehealth appointment, you can use this 99358 to report it. It also has a modifier or an additional code, the 99359 can be reported for any additional minutes beyond 30. So if you spend an hour, you could bill both 99358 and 99359, if that makes sense. So hopefully that is helpful in your question about complex care, like codes that physicians can bill for complex care. Any question on those?
Oh, that's awesome. Thank you for looking into that.
Yeah, you bet. Anyone else have any comments on those, or have they used them with success, per chance? All right. And then we had a few good cases go out over the listserv this last month, and I just wanted to follow up on one. This was a provider was looking for some resources for a patient with Tourette's. So I wanted to highlight these that came in through this network, which is great. This group share network. If people were curious or had wanted to know the outcome of that question. So recommended recommendations were the Utah Tick Lab, which operates on a sliding scale fee basis. The Utah Life Skills Clinic, or University of Utah Life Skills Clinic, which offers comprehensive behavioral intervention therapy for ticks. And then the Tourette's Association of America, which has a really nice provider search tool that includes telehealth options, which I know this the provider that asked, I believe, is located up in Weber County. So a telehealth option might be really helpful there. All right, we have a few other minutes. If anyone has any other cases or announcements or things you want to bring up today.
Hi, Athena. This is Dora from Shriners.
Hey, Dora.
Hello. I just wanted to share that we have Dr. Brittany Garcia, who is one of our hand surgeons. She is opening a new service at Shriners, treating brachial plexus in the Shriners location. So she'll be doing the ultrasound in her clinic and treating that with the neuro part of it at the same time. And she's open to connecting with the providers, but just wanted to share that with you as well, that she'll be able to treat that with everything not just a portion of it. So she's excited that Shriners will allow her to do that. She's trained in 7 states for pediatric treatment for brachial plexus. So all the surrounding states, she's the only provider that is trained in 7 states and in Utah. So excited to be able to provide that through Shriners. And if you have any questions, I will put my information on there and I can send you the flyer as well.
Is there any additional thing providers need to do if referring to have that included or to access that service?
It's the same way that you refer any for anything traditional. The referral information that I have has a phone number for the families to call if they want directly that's managed by the nurses, but it can be referred just a traditional way
Okay,
that you refer through Shriners, which is just a referral form. For newborns, if there's anything that they want us to evaluate, they can do that as well. But I will send that flyer to you as well.
great, thank you.
Thank you. And like always, we take all insurances, Medicaid, underinsured, regardless of family's ability to pay.
Thanks, Dora.
Thanks for the time, Athena.
Mm-hmm. Does anyone else have a case or announcement or resource you want to share with the group?
I might have a case to ponder, and I'm sorry I couldn't find the raise the hand
Oh,
tab
that's
quick
all
enough.
right. This is
Um,
perfect.
so I I used to work in EI, and so years ago I had a cute little family. Um, Mom was actually born with a club foot. Dad's family, dad, his brother, grandparents were all seen by our clinic, and mom and dad had a couple of really cute little kids that I served on EI, and now they're 17 and 18. About 10 years ago, uh, mom and dad were not able to care for the kiddos, and maternal grandma legally adopted them. And they were seen in our clinic quite a bit with children's special health care needs, and then we haven't seen them for a while. And I got invited to a family team meeting because services are involved because our little 16-year-old has a diagnosis of autism, and uh, he is reported to become violent at home and has hit his grandma, has broke down a door, and so he has some JJS services involved. And the family didn't know if he was on an IEP or not. They had a Four Corners provides mental health, and the mental health provider there said, a severe expressive speech delay, autism, and ADHD. But he spoke pretty well in the meeting, and he reported that he does well in school. I was able to follow up with a school nurse. He does not have an IEP, and his grades are actually really good. So we talked about maybe updating, getting some current testing to see where he's at. The post-adoption worker was there, but because the grandfather also adopted them, he passed away. So the kiddos are now, he's getting, the 18-year-old isn't anymore, but they're getting death benefits through SSI. So they were kind of a little bit hesitant on maybe upping his post-adoption subsidy. But grandma's door dashing. She has some health concerns, heart issues, and like swelling of the legs and stuff. So it's really hard for her to door dash. But they're really tight on money, and he wants to get a job. Anyway, it's a big mess. It's a big mess. He seemed okay to take medication, but grandma reported that he declines taking medication. Um, when I went back and looked through all of the notes from before he was 3, with his mother, it's reported he's mean, he's mean, he's mean. I don't know if that, how what their perspective is, but he also may have and this was not touched upon, and then the mental health provider got off, but his mom's left him, his dad's left him, his grandfather has died, so his adoptive grandmother, grandma, is raising him. She has some health issues. Um, and there may be some uh just mental health things that could be uh maybe some cross-dressing or some things like that. Any referrals, and I don't need an answer now, but maybe some friendly therapists that can help him explore that in a safe way, or at least be able to talk to his grandma and sister about it in a safe way, because I think it's a really bad cycle of shame for him. Sorry, that was a big rambling mess.
Thanks, Glenn. So, if I'm understanding correctly, it's a 16-year-old with a confirmed diagnosis of autism, but who is in need of some maybe additional therapy, some mental health services.
Yeah, and maybe, and I don't know this. I don't know enough, so I don't want to presume. But grandma and sister kind of, it sounds like maybe he um has taken sister's undergarments to wear, um, and then maybe has wanted to order his own. And so I think there's a lot of maybe some control dynamics. We're going to get ICC in there too. But like they won't he can't have a job. But you know what I mean? And there may be dynamics that I just feel like he might need a more open-minded therapist, maybe um, some LGBT whatever, and I'm not, they didn't really talk about like being welcoming to that in the meeting, but it kept coming back to the undergarment things. And he is the most cutest, delightful young man, and I just wanted to hug him. And I think any resources that way, please. Sorry, I'm such a rambler.
Very good. Abby, did you have a
Yes,
comment?
yes. So how old is he? I think I missed that.
He's 16. He'll be 17 in September, but he was retained a year, so he still has, a few more years
Okay.
of high school.
Okay.
And he does
Um,
well in school.
so we do our Tetons class, and it's all about sexual health and wellness. And I think that might be a really, really good option for him. It's just it's about sexual health and wellness and safety and consent, and there's tons of stuff. So I will put the link in the chat, and then you can share that with them. But we do in-person classes, and they're like 8-week classes, and then we do virtual classes as well. Thank you, Amy. Amy put it in the chat for you. So I think that may be a really good resource for them as well.
Thank you. And the virtual option is super great. So thank you.
This is Heather, and I'm so sorry because I can't figure out how to raise my hand either. But Gwen, there's a program that was started a few years ago that's just been really wonderful in the Salt Lake area, but they do have a Provo location. It might be worth calling them, and I'll put it in the chat. It's called Encircle. It is a beautiful program, and LBGTQ. Yes. So I will put it in the chat as well because I think it would be wonderful to reach out to them. They're very inclusive. They do work with ages 12 to 25. So I'll put it in the chat.
I see it looks like Ashley added some LGBTQ plus affirmative therapists Guild of Utah link as well in the chat. I'll get that added to there. And then somebody also mentioned navigating healthy relationships with positive outcomes course. So I'll make sure and add all these links as well. to the responses in our resources of the month. Okay, great. Thanks, Gwen, for bringing that case up. We'll go ahead and move on to our learning session for today, which is about intellectual disability and mental health. And we have today with us Ashley Donham, who's the program administrator at the Office of Substance Use and Mental Health as part of the Department of Health. And just to give you a little bit more information about her, she has experience working with children and youth, young adults with disabilities, as well as individuals of all ages with mental health and substance use conditions. She currently works for the Department of Health as a program administrator, but she's previously worked at Huntsman Mental Health Institute as a recreational therapist as well. So we're excited to have Ashley here today, and I'm going to turn the time over to her.
Thank you. I will share my screen. And I always forget how to do it on Zoom. So give me 1 second. Oh, are y'all still seeing the main slide?
Yep.
Okay, all right, perfect. Thank you. Okay, so as Athena said, my name is Ashley Donham. I work at the Department of Health and Human Services in the Office of Substance Use and Mental Health. I work on the mental health team, and that is a team that is the lifespan, so from birth all the way up to death. Unfortunately, we like to say that. But my specific position focuses on mental health services for individuals with intellectual and developmental disabilities. And that is through the lifespan. So kiddos, youth, young adults, adults, and elderly. So I'm very excited to talk to you guys today. I do have many slides. So there will be a few slides that are text heavy that I will just breeze through. However, Athena has has a copy, and you are more than welcome to send it out. Okay. Sorry, I need to pick the right. Okay, here we go. Okay, so I just want to briefly talk about the difference between disability services and mental health services. So the Division of Services for People with Disabilities, or DSPD, they provide the home and community-based services for people with disabilities. The support includes community living, day services, supported employment, and various other services. DSPD does not fund or provide mental health services. In the state of Utah, we do not have a mental health waiver. The local mental health authorities, they are the public mental health provider for the state. So they provide services, mental health services for individuals, and that includes mental health services for people with disabilities. Now, the local mental health authorities do not fund or provide disability services, which includes psychological testing for disability diagnosis. And that is specifically if you were to call up a local mental health authority and say, hey, I think I have a disability, can I do psychological testing? They do not provide that. They do provide psychological testing in relation to mental health services. But if you're just looking for a disability diagnosis or disability eligibility, that is not within their scope. They also do not provide applied behavioral analysis, or ABA. In the state of Utah, ABA is not approved. It is not an approved treatment for mental health. So therefore, our local mental health authorities do not provide ABA services. So I just want to provide a little bit of context because this does get a bit confusing when you're trying to find services. So to start off, I just want to talk about developmental disabilities and intellectual disabilities. So this is one of the text-heavy ones I will not read through, but this is the federal definition of a developmental disability. So you have to have a severe or chronic disability, 5 years of age or older, and there's 5 different requirements to meet this. So you have to have a mental or physical impairment, or a combination of both. It has to develop before the age of 22. It has to be indefinite, so there is no cure for it. It's going to be a lifelong condition, and it results in three or more areas of, or sorry, functional limitations in three or more areas of life. So you can see those here. And then it requires complex care. So they have to have several different providers, interdisciplinary supports, and other assistance. So this is not just like a very simple diagnosis. It's going to be very complex, and it's going to require a lot of supports and services. So when people think about developmental disability, they typically think of very, specific disabilities that we typically see in the news and in the media or in TV shows, but really developmental disability is an umbrella term. It is a very large spectrum of conditions. It includes physical, cognitive, and conditions that include both of those. So some examples are intellectual disability, autism spectrum disorder, cerebral palsy. It can include severe seizure disorders, as well as brain injuries that occur before the age of 22. It is not limited to this list. A developmental disability has hundreds of conditions that can qualify under that definition. But I just want you to be aware that it is not, a few specific disability or a few specific conditions. It is a very broad catch-all umbrella term. Now, I want to talk about intellectual disability real quick. So a lot of people use these terms synonymously or interchangeably, and that's actually not the case. So an intellectual disability is a condition characterized by significant limitations in both intellectual functioning and adaptive functioning, and it has to develop or originate before the age of 22. Now, the intellectual functioning is determined by an IQ test, and the score of that IQ test has to be 70 or less. Adaptive functioning refers to a person's ability or capacity to gain personal independence based on the person's ability to learn and apply conceptual, social, and practical skills in their everyday life. So as noted on this slide, adaptive function abilities are determined and based on three domains. So conceptual, social, and practical. So this adaptive functioning piece is assessed through a very formal assessment, and they do examination on each of those levels: conceptual, social, and practical skills. So when we're talking about adaptive functioning, let me take a step back. A lot of individuals, when they're looking at services or treatment, providers will ask, well, what's their IQ score? Well, IQ scores alone do not give us a lot of information about the specific supports or the skills of the individual. So adaptive functioning much better determines the level of supports required. So the most common adaptive functioning skills that we look at are self-care, language and communication, community use, independent living skills, socialization skills, health and safety, work, and self-determination. Or self-direction. So these are the skills when we're looking at what kind of services does this person need? What is the level of supports do they need? These are the things we're most often looking at, not what is their IQ score. So some examples of intellectual disabilities include Down syndrome, Fragile X, autism spectrum disorder, fetal alcohol syndrome disorder, they changed it, fetal alcohol spectrum disorder, Williams syndrome, and Peter-Billy syndrome. So there's an asterisk next to autism because I wanted to highlight you can have autism spectrum disorder and not qualify or have an intellectual disability. So you can have autism, but not have impairments in intellectual functioning or those adaptive functioning. So it's important when we hear autism, please do not assume that the person has intellectual disability. Individuals with autism, right? It's a spectrum. It's people's abilities vary throughout that spectrum. So when we're talking about autism, and you don't have a lot of information, ask if they've had any IQ testing or if they've had those adaptive assessments done to help better understand what needs and supports they're going to need. So when we talk about intellectual and developmental disability, and this is now going to be a catch-all term, I'm grouping both of those together because that's often what the research does. When we're looking at the severity of these disabilities, the majority of people, so that 80 to 85%, fall into a mild category, which means that they don't have significant deficits in those like adaptive functioning skills or intellectual functioning. These are people that are living in our everyday community that we're interacting with that we don't even know. The next category is the moderate, so that's 10 to 12% of individuals, and then severe 3 to 4% of individuals, and then profound is 1 to 2% of individuals with an intellectual and developmental disability. So when we often think, again, how the media, how shows and movies present individuals with intellectual and developmental disabilities, a lot of the time it is in that severe or profound categories. And that's not the reality. The reality is these are people living in our community independently, enjoying the community. And I want to highlight again, these are people that have various different skills and abilities, and we need to, when we're asking or interacting with them, just remind ourselves that they're humans and that we need to treat them just like their peers. Okay, so we're going to shift a little bit and talk about mental health. So understanding, there should be an I in that, understanding IDD and mental health. So the research is a little bit convoluted because there's some historical context here. Decades ago, intellectual and developmental disabilities were thought to be protected from mental health. They were too disabled to be able to have a mental health condition. So over the decades, there hasn't been a lot of research looking at mental health and intellectual and developmental disability treatment and adaptations for mental health treatment. So when we look at the research now, it is very spread. So as the research says, it's 30 to 60% of individuals with an intellectual disability will have a mental health condition. Just keep in mind, again, it hasn't been since I believe it was mid-80s that this has actually become a topic. And it wasn't until about the 90s and 2000s that this really became an interest, and the psychological and psychiatric world started to investigate this and research this. So while the research is spread, we just know that there is a higher risk of individuals with intellectual and developmental disabilities having a mental health condition. Thus, there's not that historical data set for us to point to. So depression and anxiety are the two most frequently identified mental health conditions. And then again, the research suggests that mental health conditions for people with IDD is about 2 to 3 times higher than the general population. And unfortunately, as a result of that, historical segregation and stigma around mental health and IDD, they are considered a special population in the mental health world. But we know, let me go back. Oh no. Okay, there we go. We know that the mental health treatment, they do not need specialized mental health treatment. They can have the mental health treatment that every other person in the world can have. They're just, again, going to need different services. It's going to need to be presented differently. It's going to need sometimes to take longer, shorter sessions, but they are not a special population. They can benefit from the same mental health services that each and every one of us can benefit from. Okay, so these are a few more heavy text slides. So I will highlight a few things on the next few slides, but I want to take more time on some of the later slides because I feel like those are going to be some of the beneficial tools for you all to use in your everyday lives. So the next few slides are going to be talking about common experiences for people with intellectual and developmental disabilities and experiences for people with mental health conditions. As we're going through the next 3 slides, I want you to consider and think about, for someone who has an intellectual disability or intellectual and developmental disability and a mental health condition, how could these experiences worsen or acerbate both of their symptoms on the disability spectrum side as well as the mental health side? So some things to consider. Individuals with intellectual and developmental disabilities and mental health, so separately, they can experience minimally or moderately stressful events as far more severe than the average person will consider. They have difficulty coping and with stress management. There are fewer wellness opportunities out in the community. They frequently lack skills required to function every day, and that can often lead to dependence on others. They have difficulty with interpersonal relationships, and they can have difficulty finding jobs in a competitive job market. So by that, I mean not specialized programs for people with disabilities or specialized programs for people with mental health. This is the everyday job market that we would apply to. They have difficulty working in that competitive job market or even finding jobs or being considered for those jobs. They may learn more slowly, have difficulty recalling information, and difficulty focusing. Abstract concepts or thoughts can be really difficult to understand. They may struggle with considering alternative solutions or options. They may struggle with generalizing, so taking one skill or one concept and applying it to a different situation. And they may have more of a passive learning style, which can be really difficult if you are trying to verify that they're tracking and engaging and that they're understanding the information. They may have low expectations due to past experiences. And so this is for themselves. They have low expectations for themselves, but also other people have low expectations for them. They may feel very different from their peers and as a result experience social isolation, even though they're mainstreamed. So this is really important for our kiddos and young adults who are in school. So even though they are mainstreamed, they may feel socially isolated from their peers. They may be more likely to be rejected from their peers. School experiences or failures in school experiences dominate their histories, and they're often labeled as difficult students or difficult children. They may have low self-esteem. And as a result of all this, they may experience sadness, depression, withdrawal, hyperdependency on others, and also helplessness. And they also may struggle with impulsivity. So again, thinking about someone who has an intellectual and developmental disability and mental health, can you imagine how difficult this would be for someone who's not receiving adequate services, who's not supported, and doesn't have the skills to support themselves? It could be pretty difficult. So we're going to talk now and talk about what are the vulnerability factors for someone to have a mental health condition and have an intellectual and developmental disability. So there are a number of circumstances causing or contributing to a mental health disorder for someone with an intellectual and developmental disability. Remember, people with IDD are at risk of developing psychiatric disorders 2 to 3 times higher than the general population. And this is as a result of a few different kind of interconnected, interweaving influences based on the person's biology, psychology, and the environment surrounding them. So we're going to take some time and talk about those individually. So they're biological influences. So people with IDD frequently have a host of other health-related problems, including neurological conditions. So as a group, people with IDD have an increased prevalence for brain damage and seizure disorders. So that can disrupt how their brain functions. As a group, they also have a greater prevalence of having other physical illnesses like congenital heart disease and gastrointestinal disorders. That is a tricky word sometimes. Additionally, they are at a higher risk for medical and psychiatric misdiagnosis. Oh, that's just a part of their disability. That's called psychiatric diagnostic overshadowing, just attributing the signs and the symptoms to the person's disability, rather considering this could be additional disorders, additional conditions. And they're also more at risk for medical trauma, whether that's physical or emotional, which can exacerbate all of those things that we talked about previously. So some psychological factors. A person with IDD is often excluded from normative activities that we experience by the normal population, especially our kiddos. So think of sports activities, school parties, right? School birthday parties. Are they being invited to their peers' birthday parties? They can endure a lot of stigmatizing perceptions and negative social reactions and norms. As we previously mentioned, an over dependence on others, a lack of confidence, poor self-esteem, and poor self-identity can be very common in this population. And again, remember, they don't have the same opportunities to gauge in the environment and kind of those self-wellness and well-being activities that the normal population has. So they don't have the same opportunities to kind of develop that self-identity and self-esteem. People with IDD have prolonged exposure to negative social conditions, and this can include labeling, rejection and social disruption, segregation, restricted opportunities. Again, they don't have the same, sorry, I'm losing my voice. They don't have the same opportunities to gauge in the community, to gauge with others as the rest of the population does. And they can also be victimized. So people with IDD are at a higher risk for physical, sexual, and emotional abuse. And the one thing that I could talk about for hours on end is disenfranchised grief. So people with IDD experience this at higher rates than the rest of the population. And disenfranchised grief is grief that is not or cannot be openly acknowledged or publicly mourned or socially supported, or is just misunderstood or trivialized. So when we're thinking about people with IDD, they're often not informed or told about a death or a loss. They have cumulative lifelong losses. So thinking about attachment and bonding with their parents, absence of opportunities to form their own identity, lots of moves or losing familiar environments, dependence on others. So staff turnover can be a really important loss for people with IDD. They lose their health, right? They are at higher risk of having all these other health conditions. And then institutionalization. So this could be including a loss of contact with their family, their familiar environments, their rights, their privacy. So this can accumulate over their life, and a lot of the time, their losses cannot be seen as important, or they'll just get over it, which can result in really significant emotional trauma for individuals with IDD. So this is something to consider, particularly for our young adults and our adults. So social, people with IDD are often social isolated and do not have social networks that are common in the general population. So a lot of the time, especially for adults with IDD, their social networks are made up of family members and paid caregivers. They don't have a lot of opportunities to make friends and socialize, and that could be with people that also have IDD, but that could also be people that do not have intellectual and developmental disabilities. They're less likely to have naturally developing friendships. And again, this can be really problematic when you have someone who is seen as a significant person, whether that's a friend or a loved one, and then they leave their job. And if someone with intellectual and developmental disability continuously feels or experiences that, that can be very traumatic and have grief, but it can also disrupt their ability to make friendships and form bonds with others. Due to the lack of experience with social situations, people with IDD also become very vulnerable to be taken advantage of sexually, financially, and other ways. So this is also partly because individuals with intellectual and developmental disabilities are taught to comply, right? They're taught to listen, to follow rules, and they can be easily intimidated or coerced by others. So when we're thinking about friendships in learning how to interact with others, the Tetons program is an amazing, amazing program to get someone involved in, to give them the skill sets so that they are not vulnerable to these experiences. And then lastly, the family risk factors. So the reaction of some families having a child with a disability can be a risk factor. When parents give birth or receive the diagnosis that their child has a disability, there can be a bereavement process, which, if not handled or they don't have the right supports, it can disrupt that bond between the child and the parent. So that's a really important consideration when we're thinking about, even if the child is elementary age or youth, young adult, even thinking about going back to how was the early development stage and in bonding can be a really important consideration. So individuals with IDD and their families, they go through lots of transitions, a whole series of life transitions, and each one can lead to a crisis. It can be very difficult. So some of the transitions are the initial diagnosis or even having the birth of a child with a disability. Beginning school can be very complex and lead to crises for the family, but also for the child. When they're surpassed by a younger sibling, transitioning out of school and entering the adult world, in any onset of a new condition, whether that's psychiatric or physical, and then death of parents or death of a significant family member or caregiver who has been taking care of that individual. That can lead to a crisis for that family or for that individual. And then sometimes parents can have difficulty letting go, letting their child have a little bit more independence, especially in adulthood, right? They can be a little bit overprotective for these individuals, which can lead to that difficulty for people with intellectual and developmental disabilities developing a sense of themselves, developing skills to interact with others. So it's a little bit of a complex situation. So one additional consideration I want you to think about is that family members, the parents themselves, can have a diagnosed or an undiagnosed intellectual and developmental disability. And so this can really impact their ability when we're talking about care. So they may struggle with making and keeping appointments and maintaining schedules. Sorry, I'm trying to move this for myself. They may struggle with completing paperwork and applications. They may struggle with meeting deadlines. They may struggle with following instructions and also caring for themselves in this complex situation. So just things to consider. Not that we're diagnosing families, but it is a good opportunity for us to check in and help the parent understand what works best for them and how we can help support them. So they may need additional assistance to do these following things. So some basic support strategies. So making sure that we're providing positive behavior supports. Communication, I have a few more slides that will specifically talk about that, but just make sure that when we are engaging, that it's the interaction is social. We're not using a demanding approach. When we're talking about the environment, it's important for us to evaluate that environment from the person's perspective. So looking for things that may contribute or actually cause any kind of triggering behaviors. So thinking about noise, are the temperatures uncomfortable? I'm always cold. And so going to my medical appointments and their AC's blasting, I may be really uncomfortable because I'm always cold. Poor lighting. So that could be it's not bright enough or it's too bright. Uncomfortable clothes. So thinking about those really scratchy gowns sometimes people have to wear at the doctor's office. A lack of privacy may be uncomfortable for some folks. Visual overstimulation, lots of different colors, different pictures, lots of people moving, and maybe being in a limited or tight space. So these are just things to consider if how they would like the environment to be and if we can accommodate in the most possible way that we can. So remember, providing people choice and control over their own decisions. That is part of person-centered care and self-determination. Utilizing relaxation techniques. So that could be in the appointment if you feel like they are overstimulated or just overwhelmed. And then exploring, validating, and problem solving with the individual, just trying to be as supportive as possible can really help form a therapeutic relationship. Okay, so I have a few more slides and I know I only have a few minutes left, so I will briefly go through these. So communicate clearly, use simple language, avoid jargon. In the medical world, we can use a lot of jargon and acronyms. Avoid terms that are complicated, technical, or difficult to understand. Speak slowly and pause frequently. Sometimes when individuals have difficulty understanding, we tend to speak louder and not slower. So that's something to consider. Ask one question at a time. Be patient, give them enough time for them to understand, comprehend the question, form an answer, and then respond back to you. Use concrete language instead of abstract language. So instead of are you sad, or sorry, say are you sad instead of how do you feel? Reinforce language in different formats. So that could be physical demonstration, using pictures, simplistic printed bulleted steps, just helping them understand the information in the best way that they can. Again, be aware of the environment. Lots of noises and voices can be a huge distraction for folks. Communicate directly with the person. So if they have an interpreter or if there's a support person there, make sure you're communicating with the individual, asking the individual questions, allowing the individual to answer those questions. And then ask them if they need help before just jumping in and giving them help. Let them, again, develop that sense of independence and self-determination that they can do things for themselves. So a few more, be respectful, treat them as you would their peers. So if they're a child, treat them the same way you would treat a child who doesn't have this disability. And if it's an adult, treat them the way that you would treat a 34-year-old who doesn't have a disability. Include them, ask them questions, allow them to answer. Provide cues. So especially if it's going to be a long appointment and there's going to be multiple steps in the appointment, try and give them transitions, let them know what the next step is going to be approximately, in a few minutes. In 2 minutes, we are going to move to the next room to do x-rays or whatever, take pictures of your bones. Please consider the trauma of the individual, of the family, and use a trauma-informed approach. When you're providing instructions, use very simple steps. We may need to consider breaking the steps down further into smaller steps for them to be able to complete it. Consider accommodations. Different people need different accommodations, and needs change over time. So we should be checking in with the family or with the individual regularly. And then consider working with other professionals. So again, they may have a very large team of people working with them. If they have DSPD funding, I would highly suggest that you work with their support coordinator. So asking if they have DSPD funding, who is their support coordinator, and getting that individual's information. And then if they are a child and they're in primary care, they do have the child life specialists who provide the adaptive care program. I have that linked so you can find out more information about that. But that is an amazing, amazing program to help reduce medical trauma experienced by families and individuals. So these are examples of communications tools that you can use. So sequencing, a visual schedule, and communication boards. These are some things that I've used when I've worked with people with disabilities. I would suggest, if it's going to be a long appointment with lots of different steps, asking the parent if they already have something like this and working with the parent to create it. And if the parent doesn't, maybe creating it in your own. It is not something that you need a lot of technology for. You can simply just copy and paste images off Word and put them, or sorry, off Google, and put them in a Word document and print it out. Remember, giving them as much information in preparation is ideal, but giving it in a format that they will understand is even better. So some quick additional information. I just want to encourage you to learn as much as you can. These are some of my favorite books in movies or documentaries about people with disabilities. I would highly encourage you to watch Crip Camp or The R Word. And then two of my favorite books here. Disability Visibility is a collection of essays by adults with disabilities. And it is very moving in some of the stories are heartbreaking. So be prepared, maybe have some tissues. There is the Utah Parent Center dual diagnosis module that is available on their website. And then these are just various resources that I've collected over the years that can be found on the internet. And then these are two resources that we have in our office. So this is an education series for professionals, and we talk about various different disability-related topics. And then this bottom one is a new resource that we have. It's not completely public yet, but it is living on our website. We have created kind of a mental health provider directory. So these are mental health professionals that have self-enrolled to be listed. And then here's my contact information. Sorry, that was right at 9:30.
No, that's perfect, Ashley. Thank you so much for being here today. I'm sure there are some questions. I'm happy to stay on if people want to ask some additional questions. And then just as a reminder before we wrap up and some people have to leave, our next meeting is August 12th and will be about special education services. So if we have any questions for Ashley, we'll go ahead and open it up and just stay on a few extra minutes for all those that can.
Yeah, I'm happy to stay on.
Can you go back a couple slides? I wanted to take a picture of the resources that you've put together over the time.
Yeah, I'd be happy to. So
Oh, sorry. I'm also going to attach the slides to our resources of the month email that will go out. I usually send it out the day after our meeting, so all this will be in that email as well.
Yeah, and we will actually be putting, it's not on our website yet, but this page right here, we will have a resource matrix on that page, and we will have resources related to mental health, suicide and crisis, trauma, grief, and substance use. So that is coming in a few weeks, hopefully.
There was a comment in the chat about the provider list. That is very exciting, and I think that will be used by a lot of people on this call. So
Yes, and if it's okay with you, Athena, I can also send you a flyer. We
yeah.
are encouraging providers to list themselves. So if you have ever worked with a mental health provider, and that can be all the way up from a psychiatrist down to a substance use counselor, and you know that they treat people with intellectual and developmental disabilities, please encourage them to enlist themselves. And I can provide that flyer.
There's a question in a chat about, are there recommendations for PCPs for people with special needs in Utah?
My position is specifically focused on mental health and substance use, so PCPs is a little bit out of my scope. I will let other folks tag in if they know the answer.
I think, Abby, are you asking if that resource list is included on the website? Oh, she doesn't have a mic. Okay. Well, maybe we can.
If Abigail wants to reach out to I mean, it depends on the area. And I guess
Mhm.
I would, Athena, I don't know if I should be talking, but I mean, there are many primary care doctors in the state of Utah who are willing and able to care for people with special needs. So if there's a particular area, if you want to reach out to our team, I could help you maybe find someone. I don't know if that's helpful.
And yeah, Abigail's with Wasatch Pediatrics. I can't remember which office she's with, but Draper. So, um, yeah, it'd be great.
And this is Eric. Just from a pediatric perspective, of course, we know there are lots of amazing offices that are primary care providers for children and youth with special healthcare needs. The fact that we work with getting transition age youth and young adults over to a primary care provider, that has proven to be just a little bit more of a challenge. But we're in the process now of trying to create a resource database that will include primary care providers who are willing and able to take on uh, youth and young adults with special healthcare needs. And we've created a questionnaire for those providers to indicate what types of young adults with, special healthcare needs they might be more comfortable to take in the office. So intellectual disability, neurodivergence, all sorts of different types of things, and how they can accommodate those people, those young folks in their office. The database is not quite up and ready yet, but that's what we're looking to have available here, hopefully in the next couple of months. And I'm going to just publicly tell Ashley how much I worship her because she gave me the idea for how to do this kind of on the cheap. It was a great way to kind of put something out there that didn't cost us $1 million. But this idea is taken off of her provider list for providers who work, mental health providers who work with intellectual disability. So, Addie, I'm kind of putting the cart in front of the horse right now, but eventually here we will have a list of adult serving providers who are willing to take on um, those those young adults, and it will list things like insurance taken, languages spoken in the office. Do they have quiet space for check in? Are youth and families able to interview the office and have a field trip to the office before they go in? Can they accommodate things like wheelchair scale, um, you know things like that would kind of be generally applicable to our population who may have disabilities, both intellectual and physical. So, and it's one of those things too that as we put out that questionnaire to those providers, it's going to be a self-enrollment type of a thing. So we would only have providers who are willing to be on the list. It won't be like, an insurance list where you call 50 people and all 50 providers aren't accepting new patients. This would be kind of a self-enrollment sort of a thing. And I will also encourage you to reach out to Natalie Allen if you do have patients who are looking, because Natalie does know some folks and have some connections, and that could be an interim solution for you. And I did not mean to take up so much time, Athena. I apologize.
No, you're good. You're getting really positive feedback to that as well in the chat about the need for a list, especially for young physicians that'll see young adults, and that will be really valuable when it comes out.
And
Yeah,
if it's
Ashley.
okay, I'm going to add in one quick thing. I have been working with the Office of Population Health to develop a collection of resources, whether it's toolkits, trainings, webinars, certifications for various healthcare professionals. And that includes administrative staff, case managers, care managers, all the way up to physicians, to learn about disabilities generally. And so that hopefully will be released in the next coming months out of the Office of Population Health.
It's great.
Ashley, if you have one more second, that second resource, the one that you showed that had the two, there was one above it that you talked about that it was educational. What is that for? Who is that designed for?
It was originally designed for mental health professionals to help them understand the just disabilities, intellectual and developmental disabilities specifically, in the disability service sector. However, we actually had a lot of RNs and care managers also attend because they also don't know about disability, specifically intellectual and developmental disability in the service sector. So it's really open to anyone who's wanting to learn more about intellectual and developmental disability and that service sector.
Is it asynchronous or do you teach it at certain times? Like, is it an online learning module?
Nope, it is individual webinars that have happened over 2 years. So there's
Oh, okay.
22 different topics that are on there, and they just have to self-enroll, and
Okay.
they can get CEU credits if they complete the survey at the end.
Okay, perfect. I'll look
Yeah,
for that link. Thank you.
no problem.
Great. Any final questions for Ashley? All right. Thank you everyone so much for joining us today. I'll be sure and send all these wonderful resources and links we heard about out through the listserv, and we'll see you all next month.
Thank you, everyone.
Thanks, Athena. Thanks, Ashley.
Thank you.